All right, thanks, Alec. Great intro. Very impressive CV there, Eren, that we heard about. Some tremendous wins to your credit there, including Udemy and now Carbon Health, and some similarities. But also, I think where we should start is probably what Alec alluded there with the this being so essential and so critical right now. So, Carbon Health has been involved in the COVID-19 pandemic essentially since the beginning. So can you give us a bit of background on sort of what Carbon Health's role is there?
Sure, and thank you, Daryl, for having me. At Carbon Health, our mission was always making great care accessible to everyone. And we were doing this in normal primary care, urgent care, virtual care type of settings. In a very technology-centric approach. But when the pandemic first started, I guess even before it was called a pandemic, in January, we started tracking the coronavirus risk. And we have our technology platform, which usually screens patients before they come to the clinic. And just to be safe, we added some screening for potential coronavirus type patients. This was early January.
Wow, so that's before even the US was really treating it as anything serious, right?
Exactly. So it was around January we started working on this. I think like January 15 is when we had our first official, what do we do about coronavirus meeting. So we started tracking people remotely, screening for people coming from, especially China. And we realized that once we launched this system, 2 days later, there were 2 patients coming from Wuhan, China, our clinics, with respiratory symptoms. So we obviously just kind of flag those, just usually at that point, CDC was the only place doing testing. We route them outside our clinics ASAP. But we realized this was not a remote problem. There were a lot of people going back and forth from China, and it was already outside Wuhan. So we just assumed that it was going to be here sooner or later. One of the first things we did was a virtual monitoring program. So because we couldn't do typical testing, we just asked them to stay at home, monitor them daily, would ask them daily questions about to see how their symptoms were changing over time. And there were a couple of people who were coming from China directly who were testing positive, but also one of the patients we had that really looked like coronavirus, but had no travel history. Was not tested, and eventually that person ended up in the ER. And I think it was kind of later announced as the first community spread patient.
Wow.
Which meant it was the first patient which is acknowledged as a person who got it from somebody else in the country, not from the travel history. So in reality, that person was almost certainly not the first community spread patient.
Right.
That was the first one.
First we know about, right?
First you know about it, in California, because we were tracking it. So I think it was very clear to us that in the near term, we assumed in the beginning that for at least 6 months, coronavirus care would completely dominate healthcare, because patients were not wanting to go to clinics for any other reason, and we would be all working on this. We decided to pivot almost all of our resources into how we can best respond to this pandemic. And over the year or so, we have essentially every one of our teams have done things in the best of their skills to help respond to the pandemic.
Gotcha.
We have hundreds at this point, thousands of doctors on the ground, on the front lines working. We had our engineers building software technology systems. We have our data science team launching large data sets to help researchers. We had our marketing team creating educational content. It was really just a full company effort, and we just acted like if the president gave us the responsibility to fight the pandemic, what would we have done?
Right.
And that actually resulted in maybe a dozen kind of innovations over the last 12 months, which are all helping in different areas.
Great. So, I mean, that's a good point that you bring up about it being as if you had been tasked for a national response, and yet you absolutely had not been, right, at that point. So, and the contrast is that you had public health agencies moving with relative sluggishness for various reasons. But, how much of that was your startup origins and your startup approach and your startup experience, seeing this thing and then saying, you know what, let's move the ship entirely, like, you know, and do it right now, regardless of the risk that incurs, which could be a tremendous risk. Like if it does go away, that's a massive reallocation of resources to deal with, right?
Yes, I honestly, I'm right now describing it as if it was obvious to us, but in reality, we had those long debates, and even I was not actually completely convinced that coronavirus would be turned into a pandemic. So we had our VP of product, for example, Ayo, like was very worried about it. So he thought this could be really, really bad. There were other people which had more kind of balanced opinions, and some of us thought like maybe we would be able to just pass this. But what we end up kind of deciding was that if we overthink this, if we get overly prepared, worst case we lose some resources. So it's just a lot of money and maybe time. But if we are wrong and this actually becomes a full-blown pandemic, then we would wish we had started this as early as possible.
Right. Yeah.
And I think that's the biggest problem with the federal government, was that they just did not take this seriously for so many months, right? So, and as you alluded, so nobody tested us with doing any other things. We didn't get permission. We just tried to start doing things. And in contrast, even after this became an actual pandemic, like formally, local government usually went to the largest companies they know. They went to Google and CVS, Walgreens, and Amazons of the world, which, I mean, yes, federal government had a weak response, but I think these large companies also did not really put that much value either. So just compared to how much trust was given to them, I think their response was somewhat disappointing as well. And what we did is we just really just said, like, how do we do this? When CDC allowed testing, we launched testing across all of our clinics. We thought that rapid testing was going to be extremely critical. So we started working with Abbott, and the moment Abbott's rapid testing was available, we just, like the same day it was technically approved, it was already, all of our clinics.
Wow.
So, and I think one of the things probably that was most impactful was we were really concerned about the nursing homes, because if you looked at the fatalities, majority of them were happening in those registered nursing homes or other kind of senior living communities. And one of the local nursing homes emailed us, and they said like they had 2 staff members who were positive. I mean, at that point, there was no CARES Act, there was no program for this. So our chief medical officer took a team of people, and then we just went there, tested the entire population, also tested the other more complex symptoms, problems that are ER physicians on board. And we actually called multiple residents and multiple other staff members who were already positive. So we were able to kind of isolate them just in time. So if we hadn't done that, likely it could have turned into an outbreak. Yeah. So we did this type of things, and eventually the kind of governments caught up. Like, for example, San Francisco local government eventually saw what we were doing with a couple of these nursing homes, and they just turned it to a full county level program, and they just created the budget for us to do this across all of the nursing homes, not just 1 or 2 that we could reach out directly. So we really just, I think most of the things we just started, did not take permission, did not ask for permission. We just provided the value, and people obviously noticed that. And then we were kind of slowly given more and more responsibilities as we were just doing a good job with that first step. Right. I think even in San Francisco, it started from just like one place to now we are helping run almost all the kind of major San Francisco city testing initiatives with a company called Color Genomics. We partnered with a lot of different organizations in this. It was not a singular effort, but it was really just step by step. As we did something well, we were asked to do the next thing.
Right. And so how does that compare and contrast to, imagine in non-COVID times, like what would that process be like, trying to work closely with government in that facility, and then gaining that kind of responsibility? Because it seems like as much as the pandemic is obviously horrible, but it's nothing anybody could have likely prevented. So it seems like a benefit has been encouraging that kind of cooperation.
Exactly. I think one of the silver linings, as you are mentioning, is that now the governments have a way to work with private companies and nonprofits in a much faster timeline. So I'm guessing that this actually ability to quickly quickly facilitate a partnership is going to stick for other problems in the future. So that is going to be one positive. But beyond that, I believe the way governments typically work with private companies was actually broken. Because the traditional model is a vendor model where government identifies a problem, creates a budget, and this takes a very long time.
Yeah.
And then they create a specification, usually called the RFP, request for proposals, and then they publish it.
There's a period of,
for private companies respond to this RFP, and then they will build something in like a long time. And usually by the time the solution is live, it's just really outdated and wrong and broken, but it doesn't matter because what really happens is the process is still clunky. The only parties which are really winning these contracts are not the ones that could best respond to these problems. They're just the ones who are most used to doing government contracting.
Right. Yeah.
So, and even if you look at CDC partner with Deloitte to build a vaccine management system, which was a huge failure. I think also like there was an Accenture partnership, and like these were really owned companies, which they're not really healthcare providers, but they're really the only ones who had the bandwidth to work with these government processes.
Mm-hmm.
So I believe there's actually a way to do things differently. So we can get to the vaccine, but what we did for the vaccine problem was we just designed a solution that we thought should exist. We just built that because part of what we need to understand is like local governments had the right intent most of the time, but they're not necessarily product people. They're not necessarily best at identifying what the solution should look like.
Yeah.
In the startup world, you have product people who are better at identifying what the most optimal solution is to a problem. It's not just about business needs. So similarly, we essentially use our product mindset, the bandwidth to just say, here is the most optimal solution for mass vaccination model. And we also just argued that it has to be a mass vaccination site. And we showed it to the LA mayor's office, and immediately when they saw it, they realized this was what they needed. This wasn't what they were necessarily thinking about before, but just when they see it, they realize, yes, like they realize it, right? This is actually what happens with a good product in general is the consumers don't necessarily know what they want.
Yeah.
But when they see it, they immediately respond to it, right? They know this is what they want.
Yeah, it's the classic, Steve Jobs is the classic example, right? Like inventing these things, not based on consumer feedback groups or crowdsourced design. Like it's like, no, this is what they want. We intuit it as product people, and then it ends up being the thing that is needed, right?
Exactly. And here we have an advantage. We are healthcare providers. We work on the ground. We build a technology platform. We did a lot of mass testing operations. So we kind of had a pretty strong idea about where these things would fail. And one of the common things especially in public health is, I guess in healthcare in general, people significantly underestimate the challenges of last mile healthcare delivery.
Right.
Everybody thinks about building the vaccine, getting
the basic science and doing the genetics.
We really put a lot of attention to like distribution and equitable kind of distribution and shipping and storage. It's just last mile is actually harder than most of the other things, other than the science of that. But it's just nobody thinks about it until like there are a bunch of shipments of vaccines in some hospitals.
Until the stuff's actually showing up at your door, and then you're like,
exactly. So, the other kind of thing which is not maybe obvious is building the software solution for this. It actually has the longest lead time. So then like logistics is important and hard, but you can, once you do it, you have it. Versus software, you really need to start earlier. So I think that some of the things we had insights from our other type of work. So when we pitched that, City of Los Angeles was really struggling with the kind of government, like state-sponsored system. It was crashing. It was not able to handle the load. It was not really capturing the real complexity of the vaccine distribution. So it's really flipping it. So instead of waiting for an RFP, building the product, pitching it, getting it approved, I think is a much more interesting model. And we're actually making an experiment. We will be starting a public health division. So hopefully when COVID is over, so this division is going to think about what are some public health problems that we could try to help with a technologist, product person mindset. So how do we provide care to unsheltered individuals? Right? It's even having a basic concept of medical records is really hard for them. So they usually only get treated in ERs with a quick triage. So like those are hard problems, and it requires significant product, technology, healthcare understanding. Like, it's not necessarily something that you would expect the local government to kind of expect a perfect solution. So you'll be just working on this type of problems. And I mean, it's not the only problem, like rural healthcare is a big problem.
Yeah.
So it's really, there's certain parts of healthcare accessibility, which you can only really solve with government partnership. You can't really solve this as a pure private company.
Right.
So, but I think like the experiment we are doing is, let's just come up with the solutions, build them, let's put up services behind them. So it's not a software only solution. And then we pitch it to governments. And then if they're okay with it, if they want to help sponsor it, then we can actually deploy it together.
Great. So that to me sounds much more like a like a consumer tech or other type of tech product cycle, right? Versus what we've traditionally thought of a healthcare tech cycle. And I actually just recently spoke to the CEO of Foresight Capital, which is a healthcare specific, VC, Jim Tannenbaum, and he was bringing up some similar things, right? Like he thinks that the cycles are shortening in terms of in healthcare and tech. And so the development cycles are getting narrower, but also on the other side, there's going to come a point where you consumerize access to these technologies in a way that resembles how we've done that with, say, computers, right? And the smartphone. So it sounds like you're in agreement there, but I do want to talk about, the reason that I think there's been a laggard in the healthcare system is partially because of the influence of inertia and just sort of like favoritism and large deep-pocketed organizations controlling a lot of this stuff. But the other part of it is safety measures, right? So, what is lost here, or what has changed about the process where we can still ensure safety as we move at this pace, or as we change this process of checks and balances?
Yes, I think there you are hitting a critical piece. So yes, there are legacy organizations which are not changing, innovative because of the inertia. But the reality is healthcare services is the most complex service industry. Mm-hmm. If you compare this with even transportation or food, like healthcare delivery is an order of magnitude more complicated. Mm-hmm. So like imagine like if you are launching the first Uber, you have an app, somebody press a button, driver comes up, you pay the driver. So you're kind of, it's end of the story. Obviously doing this at like massive scale is challenging, like it's hard, but just getting started is not very hard. Same thing with food delivery, right? Mm-hmm. So the DoorDash founders could just get a van, put up some flyers, put up a website, and they can do food delivery relatively in a low, kind of without a lot of effort. So versus if you want to provide just basic primary care, for example, from day one, you need to be able to have a medical group and be able to support prescriptions, labs, and referrals, and imaging, and there's insurance relationships. And also because it's there are a lot of regulations, and I'm not anti-regulation, just to be very clear. I think actually a lot of regulations have the right intent. Sometimes, time to time, they feel annoying, but I mean, they're there for good reasons. I actually don't blame the regulations pretty much ever. So it's just there's a longer upfront time. So, and we didn't really build a vaccine solution for LA in 2 weeks. I mean, we have built it in 5 years. Like, so we have been building hardcore healthcare technology since 2015. Like we had the entire infrastructure completely built from the ground up. So that's one of the advantages of Carbon is we really don't use any other healthcare software. Actually, made it forbidden to even look at other legacy healthcare platforms. So we started from first principles. We kind of figure out everything from onboarding the patients to prescriptions to labs to imaging to insurance payer relationships, patient portals, following up. We built all the technologies from the ground up, which took a long time. But then like once we have problems like testing and vaccines and even providing care to COVID positive patients, screening, like these are all essentially possible because we had the infrastructure. We just created the last layer in a nimble way. So, but the reality is you do need like serious infrastructure for healthcare. It doesn't happen overnight, but also it does not have to take 30 years either. Right. So like 5 years for considering how large this problem is, both economically and also for in terms of impact, like the investment that's needed is still fairly like reasonable.
Yeah, no, yeah, I think you hit it there. Like that is what is changed. Like it's not like the complexity of the thing underneath has changed, right? You're not saying let's throw out all of the responsibility that we take in caring for people's health, but the tools that technology have enabled means that you can make those things much quicker than you used to be able to, and with much more reliability, I think. Right?
Exactly. And actually, one of the things maybe worth mentioning is, like, why did the existing healthcare tools not really do this job? Right. So that was the mystery, that's a mystery for a lot of people. The problem with legacy healthcare software is that they're usually requested by the administrators, the payment billing departments. So they're typically designed as a admin billing solution.
Right.
And they over time add things like note taking and medical records, and like something like patient portal is a huge afterthought. Like a lot of platforms have built their patient portals like 20 years after after being live. So versus the approach you do need is like really what is it that the patients want? What is it that the providers want? These things are actually fairly obvious. Like it's not rocket science. Like in a way, like in healthcare, what ideal outcome looks like, ideal product looks like is relatively clear. So, but then if you start from their angle and then just go deeper and deeper into administration and regulations and billing as a required step, but not the core design, that completely changes. I think like some of the new startups, the more consumerized startups, I think maybe their biggest differentiation is that they start from the consumer experience angle and then just go deeper, which is the right way to do this. I think that's actually what has changed in the last, I would say, like 5-10 years.
So like, why has that changed from an incentive structure perspective? Because like, typically people build to incentives, right? So you were talking about those things like, it's like, well, the money part of this equation exists here at the level of, let's say the payer back office or something, right? So it kind of makes sense to build for that admin. But so what has changed that makes your model and your customer first model more viable now than it was before?
I mean, generally, there's a huge consumerization trend across all industries, right? So 10 years ago, enterprise software wasn't consumerized, but now they are, right? So now, and typically healthcare comes behind like other enterprise software. So I usually think of like consumers, a trend happens in consumer products. Actually, let's just remember that there was a time where even consumer products were not consumerized.
Right.
So really this idea of really focusing on the experience starts with consumers. Typically goes to enterprise next, typically goes to education next, and then healthcare comes like 15, 20 years behind. So this is natural kind of timeline of things. That's why I started an education company first in 2000. Right. And I started a healthcare company in 2015. I didn't do the opposite direction. So sometimes like, so right now the biggest change is like the expectation from the customer is a big one. There's some other kind of minor changes like high deductible insurance plans and patients having to pay more out of pocket. But really like those are just not as important in my mind. The two trends is consumers are expecting it. And also the way the healthcare costs are increasing in the United States is not sustainable.
Right.
If it goes like this, it will bankrupt the whole country. Let's just we have to realize it's like it's at 20% of the GDP right now. If it becomes 30% of the GDP, like this might actually just start a domino effect, which will literally just turns into like an unmanageable crisis. So so I think there's a pressure on this side, expectation increasing from this side, and a solution is going to pop up right now.
Yeah. So let's talk then a bit about your work behind the cost pressures, right? Like you mentioned Udemy, and that's like a great example of making education much more accessible versus the traditional academic and higher education institution model, right? So what does Carbon Health do in that regard in terms of accessibility for people of all income brackets and reducing the cost to everyone in the chain?
Yes. So the first thing we do is we started the entire company with that idea. Like our goal was not to create a healthcare company with great experience, even though we do that. The goal was to make great care accessible to everyone. So we just made it a design constraint that this has to be accessible to pretty much the entire population.
Gotcha.
So that was from day one as a kind of requirement, like spec. Spec number one, it has to, and the way we define this, Medicare has a standard reimbursement rates for every type of service. And that's a rate that everybody is willing to pay across the entire country. So we said, this is a fair rate. We'll just fix the price. We are not going to make $1 more than this. We are not going to ask for anything more. Within this reimbursement rate, what's the best healthcare that you can get if you put the smartest product people, doctors, designers, operational minds together? So that was really the kind of whole idea behind the company. And so this is extremely unusual for a healthcare company. Let me start with that. Typical healthcare business strategy is you create a regional monopoly in a specific area. So when you have the regional monopoly, all the insurance companies, all the payers have to pay you whatever you are asking for.
Right. And
really the business model is using the regional monopoly power to jack up the prices to 3-4 times what a reasonable price would be. And then you use the money to buy more entities, create even more local density, and then all of a sudden you're just really overcharging in a certain region, causing massive increases in overall prices. Right.
That's kind of like I'll take a shot at them. It's kind of like the cable model, right? It's like the cable model or the internet service provider model.
Exactly. They're not technically monopoly because they're not national monopolies, but that regional monopoly uses it to jack up prices. And that is what I'm describing is not a spatial, like one company's evil strategy. This is the entire healthcare business strategy. Like when I talk to healthcare investors and tell them that we are fixing our race to Medicare, they look at me like I'm the stupidest healthcare entrepreneur ever.
They're like, get out.
So it was like, get out. You don't understand healthcare. You're just a naive technology person. You don't understand. Like just build that iPhone photo sharing. That's the reaction I've been getting for like 5 years now. So, but really, but we're very intentional about this because when you fix the price and then you can actually go nationwide, you'll possibly become the first true nationwide healthcare provider. And then I think the second step is you build an extremely strong front door, and then you can use that influence to pressure the rest of healthcare services to bring their cost to a reasonable level. So because insurance companies don't really care about reducing costs. That's one of the kind of the misunderstood topics because they have fixed margins.
Right.
If total cost goes down, their profit also goes down. So, but as a provider who has a strong patient relationship, we have all the incentive in the world to get the best clinical outcome at the lowest cost possible for our patients. So it's really just building that influence layer nationwide and then pressuring the rest of the system. So they have to get rid of inefficient services and they have to really just create a high return of investment in their services. That's really how we are trying to tackle the entire country's healthcare accessibility problem.
That's amazing. And it's also, that's another thing I keep bringing up really like stupid analogies, but it reminds me of like a MacBook case, for instance, right? You're like, okay, well, we designed the MacBook Air case to these specifications. You now have to, engineers, it's up to you to design a battery that works within these constraints, right? Like the constraint is actually the fit of the container, which in your case is the pricing limit, which is very interesting.
That's a perfect analogy. And as an engineer, I believe that engineers and as builders, get the most creative if you give them hard constraints.
Right.
If your specification is build the best healthcare experience imaginable, that's relatively easy. I'll get the worst best physician to work for one patient. And then this, you can pay $50,000 per year, and you can hire a physician who has only 10 patients.
Right.
So that exists. It's just completely uninteresting, right? So, so I think the interesting piece is like, this is the cost. Just we can't even increase it by $1. What is it like? This is how you get people to create it. And actually, part of my philosophy is like the other side of this spectrum is, if you can't afford to be inefficient, you will eventually become inefficient. Like we can call it the Bali's law. So what has happened with healthcare organizations, they were able to charge very high rates, so they were able to be inefficient.
Yeah.
And slowly they became inefficient.
Yeah. No, that makes sense. And it's also great that it's built in that you have this limiting factor for the whole ecosystem, right? Like it becomes something that affects all points as opposed to just yourselves, right? Like no inefficiency can survive once you have the sort of spread that you're anticipating you'll have. Right?
Exactly. I think that once we have such a large like access point, one or two things will happen. We'll either become a very big company, and then we'll have a lot of market power, so we'll be able to push the prices down. And actually, one of the things I like about the regulations is there is a regulation called anti-kickback law, which means even if you have the largest front door, we wouldn't be able to make money by referring patients to other services, which is great. The fact that it's illegal is very good because I never had to make this moral.
You don't even think about it. Yeah.
I don't have to think about it, right? So, but really the only way you're allowed to make money is by reducing costs, right? So that's the only legally possible way, which is great. Like this is one example of regulation is making my job easier. So my board of directors does not pressure me to do things which I don't
Yes, like. It's very nice, yeah.
We're very comfortable. So, so either that will happen, or somebody else will have to just compete with us and you put up even lower prices, even better high quality care, and they might push us out of the business, and we might lose as a business. But that's like the question: we'll have something else which is cheaper, better than carbon, right? So it's just when you pressure the markets, whether you make the money or not, like it ends up being good for the end customers.
Yeah, no, that's great. Yeah, I mean, it's refreshing to hear, especially from a healthcare company. I mean, I talk to a lot of them, and I would say that's not the prevailing opinion or founding thesis for a company in the space. But yeah, that's great. I wanted to ask actually another question, kind of going back to some of the pandemic stuff. I'm just curious how much of what you've done and learned will apply to kind of your business model going forward, and also sort of, how much has your overall plan that we've just discussed changed based on it, or has it at all? Would be another sort of question.
I would say our plans, long-term plans, like has not changed almost a bit. What happened is we actually condensed the timelines from like 3-4 years to like one. Like I think the 3-year roadmap I had just happened in 18 months.
Oh wow, yeah, okay.
Like we always were planning to have mobile trailers to create access points because I think that's the best way to open up access to rural areas where it's hard to commercially put like full-time positions, but then there's some interactive, like we already had these ideas. And what happened is we said, okay, we have to just pull those ideas like forward.
Right.
So one of the other things I always thought about carbon was, yes, it's nice to have healthcare access points which are tech-enabled, but we also have to help accelerate the innovation and clinical side of things.
Mm-hmm.
So we always, my goal was to build the tech-enabled Johns Hopkins, not a tech-enabled clinic chain, right? So that was how I was describing it to our team as I was hiring them. So we always knew that we will be involved in clinical trials and trying therapeutics and really accelerate the timeline for innovation to hit mass market.
Right.
But during COVID, there were all these amazing diagnostic improvements which couldn't really go through the traditional trial processes because they were too slow.
Yeah.
So we had to kickstart a clinical trial operation to help these things happen faster. We had to start like a more diligent kind of research therapeutic clinical innovation models. It's just really all those ideas we had for the next 5-10 years, we had to put them and put it all into 2020 and 2021.
Wow. Yeah, I mean, that's like the research hospital. That's very interesting. So now you've effectively built a distributed research hospital as opposed to like one monolithic place that you go to and enables.
Exactly. And I don't mean to say we'll just like replace John Hopkins. I mean, John Hopkins' of the world still will be critical for the high-end, complex, acute problems and research around that. But I mean, there are a ton of things where it's a lot more practical to do the research on an outpatient mass market scale.
Yeah.
Something like testing a diagnostic test. It's just the hospitals are not really good at this type of things. It's a lot more practical for us to make those type of trials.
Yeah, and you hear all the time from researchers that it's a struggle to fill out their trials, right? Like that's consistently been a problem. So you start thinking about, well, if we have all these touch points all across the country, like it becomes much easier, especially with things like virtualized care supporting that, right?
But honestly, the main unlock there is technology, because you own the entire technology stack. We just say this patient comes in, offer them this trial. If they don't want, go to route A, otherwise go to route B.
Right.
We can launch this across 15 different kind of cities. So, I mean, this is one of the examples, right? So all of these things, like when you have the infrastructure that you built, these things become just applications.
Yeah.
In healthcare, the infrastructure was missing. That's what we spent the first, I would say, 3 years in. We were building low-level pipelines for billing and pharmacy and labs and imaging and data sharing. And now we are implementing applications on top of that.
Oh, that's great. All right. So you were setting the rails, building out the APIs, and now you're building all the endpoints and the actual access.
And maybe just like Amazon, we should just open, I mean, maybe we'll be opening this to other companies so they don't have to work on the railroad piece, and they can just go to the implementation stage directly.
Yeah, well, you heard it here first. Actually, I don't know. You probably said that elsewhere before.
This first time I'm saying, I was kind of doubting whether I should say this, but yeah, that is part of the thought. Like, it's just like we are doing all these things, and the goal is not like healthcare is too big for any company, right?
Yeah, right.
But can we just really help accelerate the innovation, the accessible to work across all dimensions? Is really what we are kind of here for.
Great. And so you mentioned like taking your 3-year product roadmap and effectively accomplishing it in 18 months, right? Probably plus a few other things around the edges. So like, how do you do that from a team perspective and from a company management perspective? Like, what were the challenges there?
Yeah, I think honestly, the short answer, I don't know, but it happened.
It happened.
We went from 100 people to 1,500 people in 1 year. So,
oh, yeah.
And I think like a couple of things we did well is we spent, especially me and the executive, spent a ridiculous amount of time aligning people in mission, vision, direction. What is it that Carbon stands for? Mm. And then we allowed our teams to just execute things directly because they just knew exactly what the direction was. So it was somewhat of a mix of top line, very clear to the direction setting, bottom up execution. For example, our vaccine service has been translated in 7 languages. I just saw it on the website. I didn't even know that we are doing this. So it's like I join our all hands meetings, and people sometimes complain, our employees complain that they don't know what's happening. But I have to suddenly, like, I'm hearing about most things in all hands meetings. So, I just learned that our teams in Reno has started this amazing operation with this local nonprofit and still doing great work. I hear about that on all hands meetings, and I just feel proud of it. It's just really this idea of allowing people to execute. But again, like, it's not a pure bottom-up management structure, right? So that doesn't work. It creates chaos. But I think if you just make the direction, the intent very clear for everybody, and that's what we spend time on as an executive team. And then people bottom up execute, and they have a lot of autonomy. I think that actually allows you to just go at a kind of fairly fast pace.
Yeah, no, that's great. I think it's a lesson that a lot of companies take a long time to learn, and especially startups, like they will locate that control solely at the top for such a long time. And it sounds like you've got the right approach with establish strong principles, trust smart people, right?
Yeah. Honestly, I'll admit it here that I don't even look at any dashboards and data and like how many visits are we doing. I'm the CEO of the company, but I know like there are people who are looking at it very careful about it. So it's really my job is just kind of my job is the same thing like over and over. Just I spend 8 hours every day just saying the same things to different teams just so that everybody's always aligned about what the company's goals are.
That's great parting advice from Eren Bali, the CEO of Carbon Health. Manage your companies in the same way. Sounds great. Thanks very much.
Thank you very much, Daryl. It was a very fun conversation.